I'm sure you will be seeing the slides in a minute. Okay, you can see the slides now. And thank you for my friends and colleagues who are working with me in producing the state-of-the-art, good quality slides. I need to mention my colleagues' names in the slides. As you can see that the number of patients who are undergoing TURP is gradually dwindling way back in 2005 itself. So if we are able to have an update on this study up to 2013, you can see that the TURP will be much more into a very small share. And laser vaporization, transurethral needle ablation and transurethral microwave therapy, one of the fastest technologies, have taken over a share from the TURP. Rezum is FDA approved in 2015. 2018 started in Europe and UK. There is now at least 2-3 randomized studies available comparing to sham treatment. Again, almost like Eurolift, the follow-up is now reaching the 7th and 8th year. So this is the generator. We call it as the world's costliest kettle because all it does is using a radio frequency energy to produce a high quality water vapor. And this water vapor is delivered by using this tip, the needle, and as the needle delivers the water vapor, the whole prostatic transition zone, which is the major zone for the BPH, got heated by the convective heat energy. And this is how the pre-op will be, including the median lobe, and post-op you can see that the median lobe and lateral lobes are nicely opened up. Even for Rezum, I will say you should restrict the median lobe to 1 centimeter, maybe up to 1.5 centimeter. More than that, it is not worth trying any of the minimally invasive treatments. So the whole boiling or convection happens at 100 degrees Celsius, where the energy is so high, and this energy is taken by the tissue, which results in ablation. And you can see that the temperature is the key point in creating the cell death and apoptosis. And Rezum works at 103 degrees, which is the perfect temperature for the convective energy to pass the energy into the prostatic tissue. As you can see here, the advantage of convective thermal energy is it spreads quite uniformly, it destroys only the cells, it preserves the skeleton, compared to the previous conductive energies like transurethral microwave therapy in the past, where it passes through the skeleton of the connective tissues and collagen and it destroys everything on its way. So that's the main advantage of Rezum compared to the previous failed treatment modalities like transurethral needle ablation or transurethral microwave therapy. And here you can see that the median lobes are getting nicely ablated if the Rezum is appropriately placed. And this is the staining by TTC, which clearly shows that the median lobe is becoming avascular and ischemic. The beauty of this is the urethral mucosa is maintained. The convective energy source will not pass through the collagen, so the urethra is maintained without any ischemic changes, and peripheral zone capsule are maintained. So there is no reason that patient will get any collateral damage. And this is 1 week MRI, which shows the transition zone is getting shrunk, and even after 6 months you can see the transition zone is almost disappeared. And this 3D reconstruction again shows that there is a good decrease in the transition zone volume. And in this picture you can see how the Rezum is placed. So again you will have like a fixed equipment delivery system. This is a disposable delivery system. Patient should have a normal cystoscope, and then patient's anatomy and suitability need to be completely assessed. And here you can see that patient needs treatment on both left and right lobe. There is no need for a median lobe deployment. So again, deployment should avoid directly into the neurovascular bundle. It's better to stay just above it, and once you deploy, it automatically has a fixed time, and then the needle retracts after complete deployment. After that you can come behind, make sure you're not too far away from Veru or affecting the sphincter, and you can do the second deployment. Nowadays, there are some good evidences from Canada, from one of my good friend by name Dean Elterman. You may have met him during your SAU visit in Montreal. He has done some studies to show that There is no need to have like 4 or 5 times convective therapy on the left side and right side. A good 2 treatments or 3 treatments is more than enough. Similarly, this kind of treatments at 6 o'clock, now they are avoiding to prevent unnecessary injury to the rectum, and the lower part is left alone, which protects the neurovascular bundles. It's quite common that the treatment is done only in the upper half, almost similar to the Eurolift. I will try to show some post-op images. And so this is the pre-Rezum. You can see that the lateral lobes are kissing against each other. Pre-op Qmax is 6 ml second with the post-void residue of 150 cc, and this is the post-op in 2 months time. You can see that the lateral lobes are nicely opened up and nicely flattened up. It's a good energy source, and appropriately if it is used, it will have a long-standing, it will stood the test of the time, I will say. Quite good for even the median lobe, and the anterior lobe is untreated, but you can treat the anterior lobe also, and verum montanum is preserved. And there are plenty of studies again, and because now we more depend upon the quality of studies, we got the studies comparing the Rezum with sham treatment, Rezum with Eurolift, Rezum with say TURP, and now we have got like a multi-arm studies comparing TURP with Rezum and Eurolift and ITIN. There are various energy sources in study. Again, good improvement in IPSS, good improvement in quality of life score, and even the median lobe studies showed good improvement in IPSS and Qmax improvement. And the studies wise, they're all quite supportive. There is no doubt in that. There is no point in concentrating on studies, because what we need to concentrate is what is the energy source, is it doable, and what may be the economic implications in countries like Pakistan, which I'm not aware. When the energy source comes to your country, we need to see how it is affordable, both from the doctor's point of view and from the patient's point of view. Yes, there will be some side effects, just like any other cystoscopy or any other instrumentation, dysuria, hematuria, hematospermia, and urinary symptoms, but they are all quite reversible, and the patients will have good improvement in few weeks' time. All patients who have Rezum should have a catheter. So the reason is there is a temporary swelling of the lateral prostatic lobes, so the patient will have more obstruction temporarily. So patient should have a catheter at least on an average 5 days, and that helps the convective energy to resolve the lateral lobes and median lobes, and the catheter removal will be successful. This is one of the major like a disadvantage of Rezum. Patients who never had catheter in the past, they will feel very uncomfortable on those 5 days, where those who had catheter in the past, they will think, okay, another 5 more days and I will be free of the catheter. There is no evidence of any erectile dysfunction or ejaculatory dysfunction like Eurolift. You can preserve the man potency as it is. The IAEF score and sham scores are nicely maintained. And nowadays, instead of keeping the catheter, something like a marriage between a temporary prostatic stent, Exime. I will discuss Exime a little bit in detail once I finish the Rezum. So instead of the long catheter draining the urine, which is quite annoying the patient, we can place this temporary prostatic stent for the same 5 days. So water epitherapy accepted by AUA guidelines, EU guidelines. We have nice guidelines supporting it, and as you know, EU guidelines also, there is a good support on that. All the guidelines are quite equally working on supporting the minimally invasive treatment. So decision making is based upon the flow chart, which you all may know. It's a quite commonly quoted EAU guidelines present in 2022 volume also. And yeah, so Rezum is another minimally invasive treatment, and it's always nice to have 2-3 technologies so that you will get the best technology for the correct people. Good efficacy, low complications, higher chance for preservation of sexual energy, and this is another energy source definitely is going to stay for long term. Any questions on Rezum or any questions in comparison to Eurolift before we go to the last 2 energy sources, which are a little bit small topics?
Right, thank you very much. I don't see any questions, but what is the surrogate marker for success? I recently saw a patient who had Rezum in Canada about 6 weeks back, We did uroflowmetry. His flow is quite poor, but symptomatically he is not too bad.
Okay.
So, what would be the strategy at this point?
Yeah, I mean, I will strongly, quite heavily rely on how patient feels. End of the day, if the patient feels, doctor, my water works are fine, I can see the improvement compared to pre-resume or pre-Eurolift. That is my main target to achieve. Sometimes the resume, as I said, it causes that prostatic swelling, which supposed to be temporary, only like 3 to 5 days time. But that swelling could be the reason why the Qmax is not good enough. But that Qmax may not be an actual reflection of patient's voiding in his home environment. So for the particular patient, if he feels satisfied with his urine stream and if he has no major side effects like erection or ejaculation problems, I will hold on, and maybe we can give a call maybe in another 3 months time. Here in UK we are heading towards telephone follow-up, so we won't be able to do Qmax documentation, even though it's nice to have Qmax and IPSS score documentation for all the patients at 3 month follow-up. We do IPSS and quality of life scores over the telephone, but Euroflowmetry we use very selectively. If patients we